10 deaths to date. And again, I would like to remind everyone that I don't give these data as simply numbers, but these are 10 families in our community who are grieving, who've lost a loved one, and with whom we stand with our deepest sympathies. The age range for those dates is, for those deaths, is 63 to 91 years of age. Deaths have occurred related to COVID-19 in our jurisdiction between the dates of March 20th and April 1st. And those include 6 females and 4 males. I'm also giving extended information on Fridays about our continued case identification and contact tracing work. This is specific to our jurisdiction. To date, we've sent out 598 isolation orders. We've sent out 831 quarantine orders, and we have cleared 60 people as of last evening from COVID-19, which means that based on the Centers for Disease Control and Prevention criteria, we have declared them recovered from the infection and no longer in need of staying in isolation. However, we still have the stay-at-home order that applies to them. So this isn't that people are going to begin to go about their daily life as they were before the stay-at-home order. This simply means that we're declaring that they have recovered from the infection. These continue to change on the hour, so the numbers I give you every Friday are reflective of the prior week's work, but you'll see that these are going to continue to rise based on the number of cases we have. You may also add up the numbers and wonder why they don't exactly add up to the numbers that I gave you on the number of lab-confirmed cases. But remember, I've spoken previously about what we call presumptive cases, which are people for whom we don't have the ability to test, that they have a link to a lab-confirmed case. They are a contact of a lab-confirmed case. They themselves became symptomatic, but they're mild enough to be at home. They haven't needed to go to the hospital. So we isolate them in place in their home, and we treat them as if they are a lab-confirmed case. But we don't report those in the lab-confirmed numbers because they haven't had a lab test. In a perfect situation, we would be able to deploy testing to every single one of those individuals, but we are not able to do that at this time. So you'll see there are more isolation orders than the number of lab-confirmed cases, and I wanted to again explain why that's the case. We feel like this is a very important approach to flatten the curve, because if we don't have the ability to test everyone, but we really suspect they have the infection, isolating them is really critical so they don't pass the infection on, and that they themselves have what they need to recover from the infection in place. This is simply here as a reference. You have seen this many times. There are many versions of this. I will continue to leave it in our slides, which will be posted each Friday after the press conference. This just gives you an idea of how our epi curve at the local level relates to the overall understanding of flattening the curve. These are epidemiologic terms that we don't traditionally talk about in the media or in lay press because we aren't usually having a pandemic, but we want everyone to understand what we're doing here and understand how to interpret the data and actually get to the bottom line for what it means for our community. So I'm going to continue to include this as reference. This is the Cuyahoga County epi curve for this week. We do have to have a cutoff for when we interpret our data. Analytics on epi curves and mapping takes a little bit more time than the tabulation of frequency data that you see me presenting in the slides. So these maps and this epi curve will always be a few days behind the actual numbers that I'm presenting, just to clarify why you may see a few different numbers. Also, I want to again remind everyone that this map, or the map coming up in this epi curve, are reflective of the entire county, Cuyahoga County, which includes the City of Cleveland Health Department work as well as the Cuyahoga County Board of Health work. We work very closely with our Cleveland Department of Health colleagues, and we are all contributing to the same approach. So when you see this epi curve and you see this map, please understand that that's the work of both of our local health departments. On this epi curve, you'll see that we've continued to report in blue the date of symptom onset. We do have some missing data, and you'll see where we've noted cases around missing data. We're working very hard to pin down the exact date of symptom onset, but in some cases, people are on a ventilator or their family informants are not able to give us exact information. So we're working our very best to get as much as we can, and we'll continue to update that information. Those are items of information that we report to the state and the CDC. So our disease investigation sometimes takes us a little bit of time to get that. But you can see a pretty nice curve on the date of symptom onset for the vast majority of our combined cases across both health departments. You'll also see the red continues to go up, and you see we are not on the other side of our curve. Okay, these numbers continue to go up, and they will continue to go up until this peaks. And again, you're hearing Dr. Acton and others talk about modeling, about when that predicted peak will play in here locally and at the state level. But there are a lot of different assumptions about those models. And so what I want to remind the public is that we're not going to get on the other side of this curve unless you stay home and you socially distance when you're not at home. And you also do the other things we're asking, which is making sure you're cleaning spaces, making sure you're washing hands. Those are the things that are going to help us get on the other side of this curve, but this curve is going to continue to go up. You'll see in red, the specimens here are when we increase testing capacity locally. But again, as I've continued to remind you, and again this morning, we don't have significant testing across the community right now. So this likely represents an underestimation or a lower amount of actual infections than are truly in our community. So please understand when you interpret this, this is only reflecting the testing availability we have, which is mostly for hospital patients and those who are in the healthcare workforce. You will also see in green that we've begun to also put on our curve recovered cases. When we clear someone from a case, we do what's called a discontinuation of isolation. It's really just a public health speak for we're telling you you're recovered from this infection. But we really wanted to share this information with the public so that you can see what prevention looks like. You can see the results of case identification and contact tracing. And the more we see this increase in cleared cases, the closer we'll be to being on the other side of this epi curve. So we will continue to share with you these cleared cases and the date of clearance every Friday. This is our map for this week. This again is a map by zip code. And so we will continue to update this each week. And you'll be able to see as this progresses over the weeks. You'll see that we have cases across the entire county. There is really nowhere in the county that's unaffected. And you'll see that as the weeks move on, the green will darken. We will see higher frequencies of cases as time moves on. And so our goal is to get ahead of the transmission so that the entire map doesn't end up dark green. But we do know that the green will continue to darken over the coming weeks. And we will continue to provide you this information insofar as it helps you to understand the distribution of cases. Please remember that these cases are always reported in their home address. So somebody may be seeking care here in Cuyahoga County in one of our tertiary or quaternary hospital care centers, but they may not be reflected in this. And when you see the hospital information around utilization I present next, just know that a lot of people being treated for this in our hospitals actually live in other local health department jurisdictions around Northeast Ohio. So these simply reflect the address zip codes of the people who've been diagnosed where they actually live, but it doesn't necessarily mean that that's where they currently are, especially if they're in the hospital. And then my final slide just explains a little bit more about some other data points which we are using to help us better understand the situation locally. I presented a percent positive aggregate estimate last week, and just to boil that down and not use so much jargon, basically that's understanding the percent of COVID-19 tests that are being done and how many of those are actually positive. It's a little hard for us to present that because the testing is being done at so many different places. And so we're having to really pull together a lot of disparate or different data sources in order to understand the true percent positive for our community. So we have tests that are being run in private labs. We have tests that are being run at the Ohio Department of Health on a very limited basis. We have tests that are being run at different hospital systems. And so in order to give you an accurate percent positive, we've had to aggregate those data, and that's a little bit challenging for a number of reasons. But we do thank our partners for providing us as much data as they could on a weekly basis so we can help our community understand the percent positive. So last week I reported the percent positive at 5%, but you also recognize in our other briefings I've talked about testing being stratified or tiered for those at highest risk for being sick, so those in the hospital. So our testing is really focused on those in the hospital and focused on healthcare workers who become symptomatic and first responders who become symptomatic. So it isn't a surprise that our general estimate of the percent positive is higher this week because we're testing people who we suspect have the infection because they're very sick in the hospital, or they're people who we know have been exposed who work in hospitals or in first responder settings. So I just wanted people to understand how to interpret that when they look back to last week's data. This again is information at the county level and includes the city of Cleveland data as well. So the percent hospitalizations of all COVID-19 cases in Cuyahoga County, 32% of those cases have been admitted at one point in the course of their illness. That doesn't mean that they're all still admitted, but it does mean that they've been admitted at some point for hospital care. The total cases in Cuyahoga County, of all those cases, 10% of those cases have required intensive care unit or ICU care at some point in the course of their illness. 33% of the cases in our county reflect healthcare workers, broadly defined, so anyone who works in a healthcare setting in any job type or first responder setting, like our firefighters and our paramedics. And then finally, percent utilization. This is not specific to any one system. What we are most interested in is the overall capacity to provide hospital care when necessary and appropriate across our county. So what you see reflected here is that we are currently at 62% of utilization or capacity for medical and surgical beds for adults. For pediatric, we're only at 31%, and these are pretty similar to last week. We actually know that we aren't keeping people in the hospital who aren't needing to be there. We always want to keep people at home if at all possible. So we have pretty similar numbers. Actually, the pediatric, we have lower utilization of pediatric medical beds this week than last week. For critical care, we're very similar to last week. We're at 69% of utilization, meaning for our ICU beds, we have 69% of what's available is currently being used. And last week I reported we were at 65% for the county. And then with regard to ventilators, we are at 55% of utilization of the ventilators we have available across the community. And last week we were at 36%. And I would like to also just clarify that the percent utilization may continue to evolve as hospitals and our state work on surge capacity, meaning as they continue to increase the number of beds available through different pathways that people asked about at this press conference Wednesday and has been discussed by Dr. Acton and Governor DeWine, you'll see that these numbers may change because this is based on the availability of beds today. And if there are increased beds open up, you might see the numbers change a little bit because now we have more beds. So we may have utilization go down. And the goal is that we never get to 100% utilization where we don't have enough beds for the sickest people and we don't have enough ventilators for the sickest people. That's why flattening the curve is so critical. And that's why we're going to continue as a public health department to work tirelessly and in a very determined way on the community side to reduce transmission and flatten the curve as quickly as we can to reduce a risk of coming up against resource challenges on the hospital side. With that,
Good. 1, 2, 3, 4, 5. Good. All right. Thank you, Dr. Gullett. Her training as an academic physician is apparent as she describes these slides. I think she's certainly a blessing to our department and to this community, and I think I'm eternally grateful for everything she does to work with us as the medical director and to really embrace her role as a community doctor here in Cuyahoga County. I have a couple folks I want to thank this morning, a few. So first, Drs. Stackland, Dr. Rose, and Dr. Tarabu, who are involved with putting together these data. They are up often in the wee hours of the morning to assure that the most up-to-date data is accurate and available for you to inform the community of where we stand during these once-a-week updates, and so I want to thank them. I also had the good fortune to be on a call yesterday with the philanthropic community, our local foundations in the region. As you know, they've reported publicly that over $5.3 million has already been made available to the community to assist with a range of social services that are critical for those that need it most. And what our foundations have done time and again in Greater Cleveland is they are there for people who are often invisible, people who are ignored, who may not have access to resources. They may need groceries because they're in quarantine. They may need assistance with medication. It may be support for the food bank through their drive-through, feeding countless families that may have nowhere else to go. And there's a range of other supports, services that the foundations are considering and embracing our community as they have. And I think we are very fortunate for their generosity and their commitment to support Greater Cleveland through this COVID response. So with that, I'd like to open up the floor for a few questions.
How has the governor's designation of the 3 zones impacted us here locally and the hospitals locally?
So the question from Lisa is, how has the governor's designation of the zones, the hospital zones that have been established, affected us locally? So I think that the best way to describe that is that our hospital systems throughout the state of Ohio have large reaches. Many have multi-county reaches. We know that we have Metro Health and University Hospitals and the Cleveland Clinic, Southwest, St. Vincent's. A range of those systems have reaches that extend well beyond the Cuyahoga County borders. And so we recognize that thinking about it in regions about care is not dissimilar to what's happening here in Greater Cleveland around the Northern Ohio Trauma System, or NOTS process, where they actually look at trauma care. I was part of the board for the NOTS board for 6 years, and in that process, they looked at trauma as it may occur in the region relative to acuity, making determinations to assure that only one helicopter would respond or one squad respond to a trauma event. And in the process, I think the model from NOTS, or the Northern Ohio Trauma System, is being used on a statewide basis as a way to assure that care is provided at the right place at the right time and by the right folks to deliver it. And so that model now, I think, has been extended statewide, and I think it's a welcome development. That way we can assure, as Dr. Gullett described, how bed capacity is utilized in the right places, looking at surge and differences in utilization across the state. We can think about how forward movement of patients to places that may have beds, to areas where they can be served. And so it allows for coordination and real-time adjustment for the clinical community. And certainly they can expound on some of those details to a much greater degree. But I think it's a welcome development, and it also shows that there's foresight going forward as we continue to climb the curve in this extended response.
With the available capacity that you guys have now in hospitals, both particularly with ventilators, ICU beds, and adult care, are you where you would hope to be at this point in the curve?
So the question is, given our current availability of beds, medical, critical care, ventilators, as well as the workforce, because the utilization isn't just about the physical pieces. It's not just about having beds. It's not just about having ventilators, but it's about having people trained to run them and provide the level of care needed for each of these folks. So the question is about, are we where we would want to be with those resources where we are on the curve? And I wish I could give you a clear answer to that, but I think it's not an easy question to answer. We are very fortunate in this community to have a considerable amount of resources from a medical standpoint for high-level care. If you're sick anywhere, there's probably not a better place to be than in Cleveland, with the number of hospitals, the number of highly trained medical professionals and teams, and the number of physical units of ventilators and beds. So what I can say is that I'm watching this closely as I see our numbers climb, but I'm also trying to work really hard with our team here to understand where we are on that curve to be able to answer Scott's question for the community on a nearly daily basis. I think time will tell. We are looking at lots of different models, but all of those models are based on assumptions. And so models can be only as helpful as the assumptions are and as accurate as the assumptions are. So we will see. We will see over the next few weeks. I do feel great about the partnership with our hospitals and also about the forward thinking around capacity and surge. And again, we do these tabletop exercises regularly in a non-pandemic situation so that we're able to exercise surge when we need it. So I feel very good about our preparedness side, but it all hinges on transmission of this virus and how many people get really sick from it.